Hello and welcome to Mead with Mead. Today we will talk about acute cholecystitis, which means inflammation of the gallbladder. Most cases happen when a gallstone gets stuck in the cystic duct, and the cystic duct connects the gallbladder to the biliary tree. It joins with the common hepatic duct, which comes from the liver, and together they form the common bile duct. So when the cystic duct is blocked, bile cannot drain properly from the gallbladder, leading to irritation, inflammation, and sometimes infection. There are two main types. The first is calculus cholecystitis, which is caused by gallstones and is the most common type. The second is called acalculus cholecystitis, where there are no stones, and this usually happens in very sick or hospitalized patients. The liver produces the bile, and then the bile is stored in the gallbladder and released after we eat, especially after fatty meals. Its job is to help digest fats and absorb fat-soluble vitamins such as A, D, E, and K. The main risk factors for gallstones and therefore for acute cholecystitis are classically remembered as female sex, obesity, pregnancy, being around the age of 40 or older, and rapid weight loss. These factors increase the chance of cholesterol gallstone formation. For example, a surgeon can increase cholesterol secretion into bile, which is why gallstones are more common in women and during pregnancy. Obesity is also linked to cholesterol-rich bile, and on the other hand, rapid weight loss can disturb gallbladder emptying and make bile more likely to form stones. So the key idea is that anything that makes bile more cholesterol-rich or reduces gallbladder emptying can increase risk of gallstones. The typical symptom of acute cholecystitis is persistent pain in the right upper quadrant of the abdomen, usually lasting more than 6 hours. The pain may radiate to the right shoulder or scapula because of irritation near the diaphragm. Patients can also have nausea, vomiting, and fever. On examination, we can find a positive Murphy sign, and this is when the examiner presses deeply in the right upper quadrant while the patient takes a deep breath in. And as the inflamed gallbladder moves down during inspiration, it touches the examiner's hand and causes pain, so the patient suddenly stops breathing in. So, compared with simple biliary colic, acute cholecystitis usually causes longer lasting pain and signs of inflammation, such as fever and tenderness. For diagnosis, we combine the clinical picture with the blood tests and imaging. Clinically, the patient often has a right upper quadrant pain and a positive Murphy sign. Blood test usually shows signs of inflammation, such as leukocytosis, and with a left shift, which means there are immature white blood cells or leukocytes, and also elevated CRP. Ultrasound is usually the first imaging test. It can show gallstones, thickening of the gallbladder wall, or edema of the gallbladder. These findings support the diagnosis of acute cholecystitis. And if the ultrasound is unclear or if complications are suspected, then we can perform a CT scan. Liver enzymes, such as ASAT and ALAT, also bilirubin and ALP, are often normal in uncomplicated acute cholecystitis. If they are elevated, we should think about obstruction in the common bile duct, such as choledocholithiasis, which means gallstone in common bile duct, or cholangitis, which is inflammation in the bile duct, and it is a serious condition. We can also check amylase or lipase to help rule out acute pancreatitis, and in acute pancreatitis, these will be elevated. And the reason why we check amylase and lipase is because pancreatitis can also cause upper abdominal pain. According to the Tokyo guidelines, the diagnosis of acute cholecystitis is based on three parts: local signs of inflammation, such as Murphy sign or right upper quadrant pain; second, systemic signs of inflammation such as fever, elevated CRP, or elevated white blood cells. And lastly, imaging findings suggestive of acute cholecystitis. When all these three are present, the diagnosis becomes definite. Treatment of acute cholecystitis usually includes supportive care, antibiotics, pain control, and definitive treatment with surgery. Preferred treatment, when possible, is early laparoscopic cholecystectomy, meaning we remove the gallbladder through mini invasive surgery. And surgery is usually performed within 2 to 3 days. Supportive care includes intravenous fluids because patients may be dehydrated from vomiting or reduced oral intake. Broad spectrum antibiotics are also given, for example, piperacillin, tazobactam, especially when infection is suspected. And for pain relief, NSAIDs such as diclofenac or ketorolac can be used if there are no contraindications. And for patients who are too unstable or unfit for surgery, gallbladder drainage can be performed instead. This can be done percutaneously through the skin or sometimes endoscopically to drain the infected or obstructed gallbladder into the stomach or duodenum. If untreated, acute cholecystitis can lead to serious complications such as gangrene, perforation, abscess formation, or sepsis. That's it for today. I hope this video helped you understand acute cholecystitis. If you found it helpful, please like, share, and subscribe to Mead with Mead. And thank you for watching.